Hi, everybody. Welcome to Bay Area Regional Medical Hour. I am your host, Abby Lee, and today we're talking all about babies. I'm so excited. We're going to have so much fun. So we have Dr. John Crochet, who is a reproductive endocrinologist and fertility specialist. Did I get that right?
You got it right.
Yes. Okay. And we also have Dr. Carolyn Kenney, who is an OBGYN. Both of them are board certified. So we're going to talk about fertility issues. We have so many questions that people have posted on our Facebook page that we're going to get to. And if you're watching live, you can post those as well, and we will be happy to answer any questions that you see along the way. And then when we talk to Dr. Kenney, this is like, I've done this once before with one other doctor. Ask embarrassing questions that most women are afraid to ask their OBGYN when they're pregnant. This is so much fun because, like, really, they are embarrassing questions. So we're going to have a lot of fun when we talk about those. And you know, you don't have to be embarrassed. We're all good. It's just part of being pregnant and part of having a baby, right? That's right. Okay, so if you haven't heard of Bay Area Regional Medical Hour or Bay Area Regional Medical Center, we are the new hospital on Highway 3, the big blue glass building. And we just opened our women's center with a level 3. We haven't gotten our designation yet, but we can take babies as young as 23 weeks in our NICU, which is awesome. So we're super excited to be delivering babies now. We started in September of last year, so we're yay. So babies. So Dr. Crochet, let's just dive right in if that's okay. So most people, I don't know how many people have problems getting pregnant. Let's talk about that.
Sure.
Real quick.
So, first of all, thanks for having me, Abby. I'm super excited to be here and talk about, what I love to do, which is to help couples get pregnant. It is not an uncommon thing. So about 15% of couples who are trying to conceive, about 12 to 15% will not have done so at about a year, and at 2 years, it's as much as 10%. So it's actually quite common.
Oh, awesome. Okay, so what's the most common cause of infertility that you see there? And there might be a couple, so you can talk about as many as you want, but what are the most common ones?
Yeah, so fertility really, I think it helps to understand it in very simple terms. And for me, I kind of think of it as 3 big categories of things that it might be. Okay, so there can be egg and ovulation issues, there can be anatomic issues, and then there can be male factor. Okay. When we talk about egg and ovulation, we're talking about female factors, and that makes up about 30% of all causes of infertility.
Okay.
So the male side of it is, and that also encompasses the second category, the anatomic issues. The male category alone is about 30%.
Oh,
and then there's a combined factor. So, as an example, a woman may have some type of ovulation dysfunction, which is a problem with growing and releasing the eggs. And then the male may also have a mild factor, like his sperm counts are not perfect, right? So about 30% of the time, there's a combined factor. And then about 10% of the time, we'll do a very, very thorough evaluation, evaluate each of those categories and not find anything. We call that unexplained infertility, which I kind of don't like the terminology for a couple of reasons. So number one, I feel like people feel defeated or they get frustrated with this diagnosis of unexplained infertility. And I don't know why, as fertility doctors, we feel compelled to put the term
unexplainable.
Yeah.
Yeah.
Because, after all, they're coming to see me for answers. I want to give them answers.
Right.
And it can be defeating. So there's a lot of other medical conditions that are relatively unexplained. For example, hypertension, high blood pressure. We don't feel the need to call that unexplained hypertension. We just call it hypertension. Mm-hmm. So I think it helps with patients' outlook on what's going on and say, look, we've done the evaluation. We didn't necessarily find any pathology. There's probably something going on. That's the bad news. The good news is there are treatments for this.
Awesome. So walk me through the process. A couple decides that they need your help. What do you do in that process? Walk me through the whole process.
Yeah, so patients will come to us, or they'll decide to come see us a lot of different ways. So we do get a lot of referrals from doctors like Dr. Kenney, OBGYNs, family practitioners, urologists. There are some patients who decide on, through internet search or through search on Facebook or Instagram that they want to see a fertility doctor. They make an appointment, and I always stress to people that are thinking about making an appointment that really this is not a commitment to anything more than finding answers. So a lot of patients are totally worked up about the idea that they're going to have to do IVF or have to do fertility treatments or have to do this or have to do surgery. And we really don't. It's really just a commitment to talk about what might be going on and talk about how we can address those things. They may be there may be ways that we can improve their fertility naturally, or it may be that they do need some of these treatments, and we can talk about why that is. But when they do come in, we sit down and have a consultation, and we go through extensively their health history, their family history, all of the lifestyle things that might be contributing to whether or not they're able to conceive. Then we do a physical examination, we do an ultrasound, we'll schedule the appropriate blood work if there is any that helps us get answers. We'll schedule any additional imaging, so we may need to do a test called a hysterosalpingogram, which is a test.
That sounds like a weird test.
What's
that?
It's actually the test that patients are probably most scared about getting because they've read.
It's got a scary name and a scary.
There you go. There you go. So they've read online about how awful it might be, and it's really not. So they can have a little bit of cramping. What they do is they come in. We put a catheter into the cervix. The catheter is teeny tiny. It does have a little balloon that holds it in place. And then we inject some contrast and take pictures of their uterus and hopefully their fallopian tubes. Okay. So it gives us a lot of really good information about the uterus, the anatomy, whether or not the fallopian tubes are open. And most patients tell me after having this, they'll sit right up and say, wow, that was not near as bad as I thought it was going to be.
Okay. So is it kind of like a colonoscopy?
No.
Okay. Yeah. I was like, something that goes in and takes pictures.
No, in fact, it's
kind of, right? No, not quite.
I'm glad you asked. Okay. So it's if you have that question, there are lots of other people that do as well. So this is it's basically an X-ray.
Okay.
So we use a
kind of like the cath lab.
Similar, yeah.
Okay.
So, but instead of using an ultrasound, we use a C-arm that takes X-ray pictures. It's called fluoroscopy. Okay. So we actually get what look like are X-ray images of the lower abdomen and pelvis, and you can actually see the bones of the pelvis, but that's not why we're looking.
Right.
But people will recognize those images.
So what do you look for?
So we're hoping. Two things. So it's called hysterosalpingogram, which means uterus. It means imaging of the uterus and fallopian tubes. Okay. So we're looking specifically at the contour of the uterine cavity and whether or not there's any uterine pathology. So things that we might see are scar tissue, endometrial polyps, fibroids inside the uterine cavity. Any of these things would show up on an HSG. That's short for hysterosalpingogram.
Yeah, I like HSG better.
HSG is way better. It's way less scary, for sure. And then we also can determine whether or not the fallopian tubes are open or whether or not they're blocked, or if they have some other type of pathology in the fallopian tube. The most common thing that we would see is the tubes would be dilated with fluid. That's called a hydrosalpinx.
So what makes that happen?
Anything that can cause inflammation in the pelvis can cause scarring to the tubes. The tubes are super, super sensitive. So any prior surgery, endometriosis, pelvic inflammatory disease, prior sexually transmitted infection, these are all things that can cause the tubes to become scarred. If they become scarred, they become occluded and they collect fluid.
Oh, wow.
Yeah.
Okay, so after you do that test, then what do you do?
So then it takes some time to get the results back of the blood work, and that's generally about 2 to 3 weeks. Okay. We'll schedule a follow-up appointment, and this is where they come in. So that initial appointment itself is about an hour FaceTime that I have with the patient. So
wow, that's a long time.
It's a long time. We spend a lot of time setting the groundwork of the discussion for what might be going on. That helps patients understand why we do the evaluation that we do and why we do the treatments that we do. Mm-hmm. So they come back for the follow-up 2 to 3 weeks later. We discuss all of the results in detail. We'll revisit any parts of the conversation that we need to, the ones that are appropriate. And then we come up with a plan, which could be anything from, look, things look pretty good. You know, there is no sense of urgency here. Let's talk about ways to improve your natural fertility. Or it could be, guys, there's a problem. You know, there's this or there's that, and there's something that we need to address. And it might be that we need to do fertility improving surgery. It might be that somebody has issues with ovulation. We need to fix that. Generally, there's a plan for any of those things that we're testing for. There's a plan. You know, there's never a time where I throw my hands in the air and say, well,
I give up. I don't know.
that just doesn't happen.
Okay, so I have a couple of questions that people posted on Facebook, so I want to answer those before we have to go to break. What tests can women have to measure their fertility?
So the single most important test, I believe, is a test called AMH. It stands for anti-Mullerian hormone. And this is the best way to measure what we call ovarian reserve. So this is egg number. It's the best way to measure a woman's egg number. The reason this is so important is because from the time a woman's born, she has all of the eggs that she's going to have. Mm-hmm. And so starting at puberty, there's a slow, steady decline in egg number and in egg quality that's ongoing, and that causes her fertility to decline. Mm-hmm. So there are a number of different ways to measure ovarian reserve. The most easy and most available way is to test this blood test called AMH. Okay.
Well, what about men?
So men, it's a semen analysis. So it's, we have them come into the office. There's a collection room. It's not as awful as it sounds. They give a sample. We put it under the microscope and we look at the number of sperm, the motility, how they look. We grade them. It's called morphology. And all of these criteria are metrics that we use to check a man's fertility.
Okay, so sounds good. So we're actually going to have to go to break. We're at the end of our first segment. So we will come back in just a minute and answer questions like, do diet and exercise affect their chances of conception? What are holistic approaches to improve fertility? I've got a ton of questions that other people posted. So we're going to have to go through these rapidly when we get back to our next segment. Okay. Good. All right. If you guys are watching or listening, you guys hold on for just a few minutes. We'll be back and we'll be live.
That does go fast.
Yeah, really fast.
Yeah.
I told you. you thought that I was lying.
And I talk too much.
And I talk too
much. All right, there it is. Hi, Dr. Kenney. Everyone at the office is watching. Smile.
Oh, no.
Sorry. All right. Now I've got Facebook up. I didn't want it to I heard yours and I was like, oh, I'm not going to do that. I'll just wait until we go to break. So. Oh, I guess. Hey, Adam, are we live on Facebook without commercials?
Sounds like it.
Oh, hey, everybody on Facebook. I'm so sorry. Okay. Hi, Renee from Dr. Kenney's office.
Hi, Renee.
I thought that we were good. I thought the commercials were rolling, so sorry about that. Everybody else is watching. Y'all give us some likes and loves and some comments. Y'all ask some questions, too. Sorry, Renee. I'm sorry. I didn't know. Normally there's commercials, so normally people can't hear what we're saying on break.
I love y'all.
You can have a good laugh with us. Oh my gosh. Okay. We got through 4 questions.
I'll talk less. I'll try.
No.
Rapid fire.
Lots of people have tried to get me to talk less.
I'm going to start taking off some. I'm going to take off that one too. All right. I'm going to do diet and exercise, holistic approaches. Which treatment do you recommend first? What are your success rates, possible side effects?
Okay.
And then we'll go into these other ones.
Is this how long is this whole thing?
An hour.
An hour.
To 5.
Services, and our packages can be tailored to fit any budget. Look us up on weddingwire.com and on Facebook and Instagram under Before the Cake Events. Sit back, relax, and enjoy your special while we direct everything before and after the cake.
Hi, everybody. Welcome back. My name is Abby Lee with Bay Area Regional Medical Hour, and we're talking to Dr. Crochet, who is a reproductive endocrinologist and fertility specialist. We're talking about so first we're gonna finish up our conversation about making people pregnant, yes, because people like to get babies, yes. And then we're going to talk to Dr. Kenney about the embarrassing questions once you are pregnant that you're afraid to ask. They're embarrassing, but we're going to ask them anyway because that's so much fun. So, all right, let's go back to Dr. Crochet. Do diet and exercise affect your chances of conception? That was another question that someone posted.
Yeah, they do. I mean, generally, I recommend that people have a healthy lifestyle. So that's eat, from a nutritional standpoint, eat healthy. It's not any different than what you've heard before. And there's a lot of different things out there about different diets. There's something called the fertility diet. There's for a lot of
really?
Yeah, it's not necessarily one that I agree with 100%. The premise behind it is that you eat full fat dairy, which for some people is fine, but that's not the answer for everybody. One of the most common things that I see are women with PCOS, polycystic ovary syndrome.
Oh, that was another question that somebody else had.
Yeah, and so one of the common things that go along with PCOS is insulin resistance, which is essentially pre-diabetes. So for those patients, I would recommend a low glycemic diet. And for all patients, I really believe in what amounts to like an anti-inflammatory diet. So there's a lot of stuff out there these days about how an anti-inflammatory diet can improve your gut health, can decrease the overall inflammation of your body. And so these are things like paleo and Whole30, and I think those are great nutritional plans for people that are trying to conceive.
Yep, I agree. And it seems like every week we come back and I'm talking to doctors, and every single week a doctor says diet and exercise will help prevent this or whatever. So it's interesting to hear on that side of things too. And another side note, we do bariatric surgery at the hospital, and I cannot tell you how many couples have had trouble conceiving. Then they had bariatric surgery, both lost 100. There was one couple, they lost 100 pounds each. Like together it was 200 pounds. And
Wow.
They were able to have a baby after they lost their weight, which was awesome.
Yeah, that is fantastic. I've had some of those same kinds of patients, and I do refer patients for bariatric surgery when it's appropriate. There are people, that's a great tool for people who are having a hard time losing weight. And sometimes people need a dramatic weight loss to not only be able to conceive, but then to have a healthy pregnancy.
Right.
So it's important in that regard.
Absolutely. Okay, so go ahead.
Well, I was going to say the interesting thing on exercise is I'm a big fan of exercise too, and I think that the extremes of no exercise can be detrimental to your health and to your fertility, but the extreme of overdoing it can be problematic as well. So I've had patients that are and not all endurance racers or runners have these issues, but I've had patients where the only thing that we can find is that they're running too much. I had a runner. She ran about 60 miles a week, and okay. No thanks. But this is, and so we had to find that balance.
Happy medium.
Exactly.
Yeah.
We had to find that balance of what was enough that it didn't mess with her mental health. Right. She said, I need this, versus something that wasn't being detrimental to her fertility.
Okay, so we were just talking about PCOS, and we had another question about that. What complications arise when trying to get pregnant when a woman has PCOS?
So the issue with PCOS is they're not ovulating. They're not growing and releasing the eggs. And really, this is probably the single most common thing that I see. I see tons and tons of women with PCOS, and it, from the standpoint of helping them get pregnant, it's actually pretty easy. So there are some things that we can do. We might come up with a nutritional plan. We might add in exercise, some of the things that we've talked about. We'll do extensive testing, and we'll address specific endocrinological issues that they might have. But at the end of the day, a lot of these women ultimately need fertility medications to help them grow and release eggs. And the way that we do it these days, we do it monitored. We're very conservative with our approach. Monitored means with ultrasounds and blood work. We're very conservative, and the risks, they're there, but they're really, really low.
Awesome. Okay, so let's get back to some of these other questions. What holistic approaches are there to improve fertility? That was a question from Brandy.
So Great question, Brandy. I think the thing that a lot of people would consider holistic, that probably has been studied the most and appears to have the most impact, is actually acupuncture. So yeah, there's tons and tons of studies about acupuncture, and you'll find studies that say it's helpful. You'll find studies that say it's not. But what you don't find are any studies that say it's detrimental. And for that reason, for my patients that may find it as a good tool for relaxation, I think it's great. I think it's a great tool for people who are coming in. Fertility treatments can be stressful. This is a great way to help them relax.
That's awesome. Okay, so what treatment do you recommend first to people when they see you?
It totally depends upon what we find. So each patient that comes in has that very, very extensive evaluation that's done, and we want to have a plan that's specific to what's going on for them. So what's right for one patient is not necessarily what's right for another. I really have some patients that, they have issues that require surgical treatment, and that's the treatment that they need.
Right.
I have patients like we talked about with ovulation dysfunction and PCOS. They may need just a little bit of fertility drugs to help them, to get them to ovulate.
There you go.
And then we have patients who have issues with their fallopian tubes, or they have severe Mel factor, and those are the kinds of scenarios that require IVF and vitro fertilization.
Okay, so what are your success rates?
So again, it depends on the type of treatment. I would say that across the board, I would consider us to be extremely successful in all the treatment types that we do. I will say that well over half of all the patients that come to us end up getting pregnant in some way other than IVF. So although I think we're best known for how we treat patients and our success rates with IVF, a lot of the other treatments that we do are successful as well. So when you look at IVF by itself, the success rates that we tell people these days, probably it depends on age more than anything else, but it's anywhere from about 50 to 70% per transfer, which is crazy good.
Awesome.
If they're doing things like the fertility drugs with or without inseminations, IUIs, then those success rates can be anywhere from about 10 to 15%.
Okay, what's an IUI for people who don't know?
So that stands for intrauterine insemination. So this is the treatment that we would do when there's a mild Mel factor. So the sperm counts are just a little bit low, or the motility is just a little bit low. That's the treatment of choice in that scenario.
Oh, okay. So are there any side effects for any of these?
There are. So
That's a broad question, so you can narrow that down as much as you want.
Yeah. So again, the approach with the medications is pretty conservative, and we do everything in a monitored way to limit the risk of side effects. The oral medications that we use for ovulation are generally very well tolerated. Some people will have mild symptoms like headaches, maybe some nausea, maybe feeling fatigue.
Oh, like what you feel when you're pregnant.
Exactly. So it's all hormonal, girl. So the other thing on hormones, one of the medicines in particular is called Clomid. I don't use it a whole bunch, but it is used a ton. It is known, it's notorious for causing hormonal type symptoms. So a lot of women or their husbands will ask about the moodiness, them being emotional. So, and I find that if you go through these things up front and people expect these, it's more tolerable.
Yeah.
So.
Well, I mean, it is what happens when you're pregnant too.
There you go.
Is there anything that can be done to improve chances of success before, during, and after treatment?
Yeah, so a lot of the things that we talked about. So, just being healthy. So having a healthy nutritional plan, getting a reasonable amount of exercise, but not overdoing it. As part of that evaluation, we're going to do a deep dive into all of the endocrinological factors that might be there. So we're going to, if there's, for example, somebody has thyroid issues, even mild, we need to handle that before they do any sort of fertility treatments.
Right.
There are different vitamins and such.
Oh, speaking of thyroid, I have a question about that one.
Yeah.
What are the effects that IVF has on? This was another question I didn't write down who asked this. I'm sorry.
Yeah.
What are the effects IVF has on people with thyroid problems?
So IVF doesn't really have an effect on the thyroid as much as the thyroid may have an effect on whether or not you're successful with your fertility treatments. So that's one of the first. Even in a patient who doesn't have symptoms, we're gonna evaluate their thyroid, because they may be on the cusp of having a thyroid that's out of whack, but they've not yet developed symptoms, and that's something that can have a dramatic impact on their fertility and then ultimately the success of their treatments. So there is there is a relationship there, but it's kind of the flip-flop of what the question was. And
Interesting.
Yeah.
All right. Let's talk about what tests and procedures you do at Bay Area Regional Medical Center.
So mostly the fertility improving surgeries. So the majority of what I would do there are what are called hysteroscopies. So this is more similar to a colonoscopy.
Okay, like a colonoscopy. All right.
Just a different part of the body.
But not as, okay.
No
got
prep.
it. We'll
No
let you
prep.
go ahead. Yeah, no crazy prep. I like that part.
So this is a camera that goes through the cervix and into the uterus. So there's no cuts or anything like that after the patient's asleep, and it's super light anesthesia, like about the amount that you would get for a colonoscopy. Put the camera into the uterine cavity. We would determine if there's any pathology there. So again, the most common thing that I would see in that scenario is a uterine polyp, and we can treat it right then and there. So it's a procedure that's both diagnostic and therapeutic.
Okay, so let's talk about you for a minute.
Yeah.
Why'd you want to become a doctor?
Yeah, so I don't remember ever wanting to do anything else.
Really?
Yeah.
Like since you were a kid?
Since I was a kid. I just always wanted to be a doctor. I always enjoyed everything about it. I actually had a blood disease when I was a child, and spent a lot of time at Texas Children's Hospital.
Wow.
Yeah, and so that was at 10. I mean,
You
even
got to
before
see
then,
it all
yeah, I
happen.
got to see it all happen, and I thought, oh, this is what I want to do.
What made you choose fertility?
Yeah, so my undergraduate degree was in genetics, and it was at a time when there were a lot of hot topics in IVF and assisted reproduction, and we talked about the genetics behind it in undergrad. So when I went to medical school, that was, I remember day one, everybody was talking about, hey, what do you want to do? What do you want to do? And I told them, I want to be a fertility specialist, and everybody would kind of, who wants to do that? Who knows that they want to do that?
Yeah.
So yeah.
You were just interested in it. Talk to me a little bit about your background in education.
So went to undergrad genetics, studied genetics at Texas A&M, did medical school at UTMB here in Galveston, did my residency in OBGYN at UT Southwestern Parkland in Dallas, and then did the last part of my training, which is reproductive endocrinology and infertility at Duke.
Awesome. So why don't you give your office location if someone wants to contact you? What's the best way to reach you?
So we have 5 locations. We have a location in just right up the road here in Clear Lake. We have a location in the medical center. We have a new location in Memorial City. We also have a location in Beaumont, and then a satellite clinic in Pearland. So the best way to reach us at any of those locations is the phone number or the website. The phone number is 281-332-0073. The website is www.infertilitytexas.com, all lowercase, all spelled out, Infertility Texas.
Awesome. Sounds good. Well, we are actually out of time. We cut that one really quick. I'm sorry, Adam. So we're going to have to go to break. Y'all stay tuned for just a few minutes, and we'll be back to talk to Dr. Kenney. All right. We had to Zoom. Okay.
Don't ever, I've heard a couple of those like interrupt their guests. It's like, okay, we have to go now. It's interesting. Yeah, let it finish.
Oh, okay. Well, there you go. Well, we got the end. We got to the end.
Yeah.
So it's all good. We kind of rushed through a lot of those questions at the end.
You're Adam? Yeah. Or what's your? Are you a radio personality? You're Adam Smasher. I thought I recognized your voice. Do you know Adam Smasher?
No. What radio station?
He was on 104.
Yeah, you did like Drive Time, right? Yeah, I remember. 39. Yeah, so yeah. Okay. We're about the same age. That's right.
We're probably about the same age. I don't know. Every other female doctor that's pregnant, I'm like 4 years older than her. So I'm like, oh my God, I'm so old. No.
I wouldn't think so.
But it sounds like a hysteroscopy. Did I say it right?
Hysteroscopy. Yeah.
Oh, I said it right.
Yeah, you got it.
Might be a little bit
Good
better.
job.
My doctor was really cool though, and this is a few years ago. Prostate cancer runs in my family, so I was having some issues. But he was really great. He was like, "Hey, I can give you a copy of this. You can show your friends."
That's funny.
I do give copies of surgical pictures to my patients. I always ask them what they're going to do with it, and they.
I think it's great.
No, yeah, it is.
I was just telling Will, who does our sports show, he came from his wife's or his sister's. She had a baby last week or the week before, and
was a guest on my show, and he's single. He hasn't been married, no kids. And I was telling him my wife has 2 kids, and like, dude, it is just it's gross, but it's
It's gross, but it's amazing. You like that, Dr. Kenny?
I like it. It's true. It's true. The first one you see.
That is an accurate.
It's, yeah.
Yeah. Yep.
Yeah, I can't imagine what you guys see, because my OBGYN for my first was like, Abby, do you want me to bring the mirror in here so you can see?
Oh, yeah, I always offer that too.
And I'm
Everyone's
like, no,
like,
I
no.
don't want to see that. I don't want to be scarred for life, okay? You might want to look at that all day, but I don't.
It actually helps some patients push. So
It does,
helps
That's
yeah.
what she was saying to me.
It helps them know, like, when they'll figure out like what works and what doesn't when they see movement. It's
Oh, yeah. That's very common.
that happens.
Okay.
Yeah, they always ask me, and when my kids were born, like, hey, do you want to come down here? I'm like, no, I'm cool. I'm cool up here. I'll stay up by the head.
It's because you're not going to the right dentist. Call Dr. Tegan and his staff at Tegan Smiles right here in Lake City, 281-334-4944, or go online to tegansmiles.com. Because seeing your dentist shouldn't be a pain. Welcome back to Bay Area Regional Medical Hour on Vinyl Draft Radio, coming live from the ECU of Texas studio.
Hi, everybody. Welcome back. My name is Abby Lee, your host of Bay Area Regional Medical Hour, and we just finished up talking with Dr. Crochet. If you're watching live on Facebook and you have some other IVF or fertility questions, you guys shoot those below, and we'll be happy to answer those along the way. But we're going to transition real quick to Dr. Kenney and talk about, well, first we're going to talk a little bit about fertility, and then we're going to talk about embarrassing questions that most women are afraid to ask, or they're just feeling, it's just uncomfortable. It's kind of awkward, right? But it happens, and we're just gonna get over it and talk about it. But you're probably one of the first people that people go to when they start having fertility problems, or you're the first one to hear about it. What exactly do you help with on the fertility side?
So I feel like my main job, first of all, it is common, like Dr. Crochet was saying, so I probably get, a few consults a week on it. And so I feel like my job is to get a good history, see if there's any factors that may be affecting their, that I may be able to optimize their fertility, and also educate. So there may be things that they're doing that they don't realize that may be affecting their fertility. I kind of go through their history, and try to identify factors that we can improve on. And then I go over the infertility workup, so which includes basic lab work, also semen analysis, like he said, and a hysterosalpingogram.
Oh, you do the fancy, the HSP thing too.
HSP,
Did I say it right? I don't know.
I go over. I prepare them for what that's going to entail, and I refer them over to Dr. Crochet in their office. Does that?
Okay, so when do you refer patients to see a reproductive endocrinologist like Dr. Crochet? At what point?
It really depends. So usually after I do the infertility workup, then I will meet back again with the couple and go over what the results were. And I will discuss things that I'm able to offer in my office, and things that Dr. Crochet is able to offer. And there are some cases where I say, I can offer you this. There's a few things that you can do to change your lifestyle that may help you get pregnant without doing any sort of treatment. Or there are some cases where I will directly go ahead and refer them to Dr. Crochet.
Okay, so say you send someone to Dr. Crochet and yay, they're pregnant, woohoo, baby's coming. At what point do you get those patients back? Or do you, Dr. Crochet earlier said, no, he does not deliver babies. So
Yeah.
I know that, but everybody else listening doesn't know that. So I'm assuming that there's like a handoff back and forth.
Yeah,
When does that happen?
It's kind of a relay race. So I'll hand it off to them to Dr. Crochet. Once they get pregnant, then I see them back around 12, 13 weeks. And that's probably the best part of my job, is getting them back and seeing them on my schedule as a new OB patient. I get really excited. I start looking through their records, and
Yay!
That's one of the best part of my jobs.
And that's
Of
one of
my
the best.
job.
That's one of the best part of my job is sending them back.
Send them back.
I call it graduation.
Yay!
So, yeah, we love when patients graduate.
That's awesome.
Yes.
That's very cool. So, okay. Anything else fertility-wise that you want to cover before we get into some embarrassing questions?
No, I think it's just important for people to know that they're not alone, that there are a lot of doctors, that's why they have infertility specialists, because there's a need for that. So I think that's the most important thing.
Okay. All right. So, these embarrassing questions that people feel uncomfortable asking. Number 1, will I have a bowel movement during delivery?
So it's funny because we do C-sections, hysterectomies, and one of the common questions on postpartum and post-op rounds is, are you passing gas? And I recently had a patient who said, I asked her if she was passing gas, and she said, no, I don't do that. And I was a little confused at first. And then I saw her look over at her husband and they kind of smirked at each other. And so then it took me a few seconds, but I said, oh, okay, well, if you did pass gas, would you be passing gas now? And so yeah, I mean, obviously, women, we pass gas, we have bowel movements. And so, yeah, in delivery, I wouldn't say 100% of people have a bowel movement during delivery, but I would say the majority of people will have a bowel movement. And it's actually, I would tell people, that means you're pushing in the right spot, because you use the same muscles to push out poop as you do to push out the baby's head.
So does that happen during a C-section too, or no?
It's sometimes, but it's usually during a vaginal delivery.
Okay,
Yeah.
That's what I was thinking, but I was like, oh, I've never asked that question
it's mostly
before.
with the pushing
Oh.
that happens.
Okay,
And it's nothing to be embarrassed about. I know it's natural to be embarrassed, but the nurses, we OB-GYNs, we're very used to it.
Used to it. It's
Yeah.
just part of it.
It's just part of it.
Let's just get
we
the baby
expect
out.
it. Exactly.
There you go. Okay, so the next question, will I get stretched out down there?
So, I guess the short answer is probably yes. I guess, to what degree probably depends on genetics, how big the baby is, how long you have to push for, if you have a normal delivery or a C-section.
But it'll go back, so don't worry, right?
It will go back to some extent, yeah.
Okay. So this is the question that I think every woman when they're pregnant, doesn't even want to talk about at all. But I'm pregnant, so I talk about it all the time because I'm like, I don't want to gain too much weight, but it's part of it, right? So
Right.
Have I gained too much weight? That's a question that maybe some people feel embarrassed to ask.
Oh yeah, that's a concern. So I always go over at my first visit how much weight I expect my patients to gain. And you have an average size baby is 7 pounds, so you should only gain 7 pounds, right? But no, obviously you gain more weight. So a lot of that is in the placenta, the amniotic fluid. You have more blood volume in pregnancy, more water weight. And so it depends on it is important to monitor that. It depends on your starting weight. So if you're a normal weight, and that's usually done by body mass index, so calculation with your height and weight, the recommended weight gain is between 25 and 35 pounds. If you have
a normal BMI.
Exactly. If you're overweight, more like 15 to 25 pounds, and then if you're obese, 10 to 15 pounds. So
Okay.
it is important to not eat for two.
Not for 2 whole adults. I say that to my
Exactly.
father-in-law all the time.
Yeah.
He's like, come on, you're eating for 2. And I'm like, not 2
No,
adults.
not so much. So increase, I guess most people don't count their calories, but 300 calories a day, which is not that much. And then also it's important to exercise. There are some conditions where we don't want, patients exercising, but for most people, low risk patients, 30 minutes a day of exercise is important.
So at what point would you tell someone not to exercise?
Well, like women who have preeclampsia, is the most common example. So issues with high blood pressure, increased activity can make the blood pressure worse. So that's
Wow.
probably the most common
And
reason.
the kinds of exercises too. I tell a lot of my patients early on that I'm concerned about them falling. So if they're doing it, I'm an advocate for exercise, but I don't want them doing things where they leave their feet. So you shouldn't be, doing box jumps and things like this if
Or
you're
bicycling on the road.
Right. I had to tell patients she couldn't surf anymore.
Oh.
Yeah. So
Ooh.
anything where you're going to be,
You could
have the
fall.
risk of fall.
Yeah.
Exactly. It's important to avoid.
Wow. Yeah, I
yoga-
went from people. I have a bicycle. I did triathlons for a while, and it's like, all right, it's time to get our little stationary bike to ride inside.
Yes, that would
Yay!
be much safer. And
Than
then
running out on the
yoga,
road.
Pilates are, common forms of exercise. Obviously not hot yoga, but those are also safe forms of exercise.
What about goat yoga?
Goat, I don't know what that is.
You have not heard of that? Oh my gosh, it's so
No.
much fun. They do it in League City.
Yeah, they do.
So you do yoga, and there's goats that jump on you the whole
What?
time. I have a
this is a
friend
real-
that
Like
does it.
baby
Yeah,
goats?
yeah.
This is baby goats.
I love baby
Like
goats.
little
you'll-
Those
baby,
videos
like
are
you should do it.
hilarious.
You
miniature
should do it.
goats.
Oh my
It
gosh,
looks
I'm
fun.
going
It
to look
looks
this
like
up
fun.
after this.
It looks like fun. Okay, so I've heard I won't be able to control my bladder after pregnancy. Is this true?
That is fairly common, especially right if you have a normal vaginal delivery and especially in the first couple of weeks after delivery. A lot of times it gets better. I usually have patients, do Kegel exercises, so basically squeezing the pelvic muscles to help strengthen those muscles. But there's some stretching, some damage done when there's nerve stretching with the delivery that can weaken those muscles that help you hold in the pee.
And it can happen while you're pregnant too, right?
It can, yes. All the increased pressure
fun.
from the pregnancy, it puts pressure on your bladder, makes it more difficult to hold in.
I always tell people being pregnant is really not that glamorous.
Yeah, it's not, and it can be tough.
It's fun though when you
Yeah.
feel the baby move.
Yeah, that
Like
part's
I
cool.
like that part. Some other people are like, it feels. This just feels like weird, but I'm like, I like it because I know he's cool, he's alive.
Exactly, and we love hearing that as OB-GYNs.
That's awesome. Okay, so is it normal to have so much discharge after pregnancy?
Well, yes. I mean, during pregnancy and after pregnancy. So during pregnancy, a lot of women, especially towards the end, have to wear a panty liner because there's so much discharge and they're not used to that. So typically that's normal unless they have, a lot of burning or itching or there's a bad odor or obviously if they think they might have broken their bag of water. And then afterwards there is discharge that's usually kind of it's bloody and then it kind of turns to a brown color, then kind of a yellowish white color.
Okay, so I have lots of other embarrassing questions to ask you, but we're going to have to go to our next break. It's crazy. It goes by so fast.
I
So if
know.
anybody else if you're watching live on Facebook and you have an embarrassing question, or if you just have a random question, we can try to answer that live too. So we'll be back. Hold on. We'll be back in just a few minutes. Awesome. Yay, we only have one segment left.
So the goats jump on you
Yes.
while you're doing yoga?
It's
Why?
little pygmy goats. They
Yeah.
crawl. Apparently people love goats and they love yoga, and why not do them together?
They jump on you because and they under you if you're like doing downward facing dog. It's hilarious.
That's so funny.
Yeah.
It's all the
Those baby goats are hilarious. I love those videos.
rave. There's one. Where do you live?
In
Live-
town.
In Houston?
Uh-huh.
Oh, okay. There's one. There's got to be one in Houston.
Oh, I'm
There's
sure.
there's one going towards Friendswood.
Oh my gosh.
Yeah, I know there's
that's
one in League
crazy.
City, like in the old part of League City somewhere on Saturdays.
Oh,
I've
they,
seen friends.
They stand on you.
They stand on you. Are you checking pictures of it?
Or I just Googled
You
it.
googled goat yoga. Yeah. It's
Oh
it's a
my
thing.
gosh. How have I never heard of this? That is so funny. I can't wait to read the reviews on this.
People love it. I have had friends do it and they were like, oh my gosh, this is so much fun.
And her goats are the sweetest.
Is that one of the reviews?
That's one of the reviews.
Hey, Adam. Hey, Adam. Adam. He can't hear me. You might want to Clorox this thing at some point. I have pregnancy nose and somebody stunk right here. And I'm like, oh. So Clorox over here would be awesome.
Oh.
He just
I don't
outed
know.
you. Yeah.
You could have left that anonymous.
Yeah.
That's hilarious.
He could have taken that. I don't know who it could
Yeah.
have been.
Who could that be?
So yeah, I don't know, but I would.
Does it smell like coffee? Does
It's
it smell-
more on this side, so whoever talks
That
on
must have
this
been
side-
bad if you can smell it now. That's really
Oh.
bad.
I'm gonna talk on this side.
the breeze.
Oh, you can. My mom is saying that they can hear us right now on Facebook. It didn't go to commercials. Hey, Mom.
Hi, Mom.
Adam can't hear you, but I can. Pregnancy note. Oh my gosh, people are texting me now. Thanks, Santi.
That is awesome.
Turn my phone.
Just turn the phone. Like turn exactly just that black phone right there. You just turn that.
Oh, sweet. Awesome. No more stinkiness. Good. I hope they're not listening. Don't tell them that I said that, okay?
We didn't say his name, did we? None of us did.
Oh, no.
No,
Oh,
we-
yeah. So he.
Yeah.
We just
oh,
responded.
yeah, he doesn't even
he
know.
did it. Yeah, okay. All right.
If I have stinky breath and I make this thing smell, then I'm sorry. Oh, my mom says hi back. And Patricia Daniel. Hi, Patricia.
That's so funny. They pee. It says they pee on your yoga mat.
Ooh.
Oh.
Hi, everybody. Welcome back. I'm your host, Abby Lee, for Bay Area Regional Medical Hour. And today we're talking all about babies. And we're talking with Dr. Kenney. She is an OBGYN. And we're asking her all of the embarrassing questions that you might be afraid to ask or you want to ask, but, it's just embarrassing and awkward to ask these questions. But we're asking them anyway because it's fun.
Yeah.
Right? Okay, so when you're pregnant, is bad gas and indigestion normal?
Again, we females, we do not burp or fart. No, it is very common. The hormones do a number on you, so they basically slow down everything in your GI tract. And so everything kind of spends more time in there and there's more time to produce gas. So it's really common for, people to have a little gas belly in the first trimester, to feel a little bloated, to have some indigestion. It's very common. And then at the third trimester, as your baby's putting pressure on your stomach and your esophagus, it's common to have the acid reflux and indigestion. So typically I have people, try avoiding spicy food, fatty food, greasy food. That can make it worse. Caffeine, chocolate, all the stuff that we like. And let gravity be your friend. So stay sitting upright for at least an hour after you eat. And then if that doesn't work, there are over-the-counter medications like Tums that can help, and then Pepcid usually
How many
does the trick.
Tums can you take in a day? I'm asking for personal reasons.
For a friend.
I'm asking for a friend. Yeah.
A friend asked me.
Tums actually has calcium in it, which is actually, good for the pregnancy and for the developing baby. So as far as how many, I usually have people take, 2 to 4 in a day. I don't know what the exact maximum is that you can,
Okay.
take before it gets dangerous, but
Okay. I'm taking at least 2 a day right now.
that's fine.
Sometimes more than that. Just depends.
Yeah.
Okay. Duly noted. Noted. Okay, so what can I do to ease digestion issues? I think we just talked about Tums, and anything else that you recommend for people? Bland diet.
Yeah, and right, bland diet, and then overall eating healthy. The other thing I forgot to mention was that, people are used to eating their 3 full meals a day, breakfast, lunch, and dinner, but it is important in pregnancy to space it out and do smaller, frequent meals. That way your stomach doesn't get as full.
And you don't get nauseous as
Yeah,
often.
exactly.
Speaking from experience, it's crazy. I started doing that, eating every about 3 hours or so, and it has
Right.
helped so much with nausea too. So anyway, this is another question. I know this from personal, but most people may not know. Can I sleep through labor?
So you can, people who have an epidural, I've seen take a nap in labor. We were talking about active labor.
Well, yeah, because you can't feel that.
Right. But
So non-epidural.
I have never seen that. I'm sure there's someone out there who has taken a nap during active labor, but maybe in early labor, taken a nap. But I have personally never seen anyone without an epidural fall asleep during labor. Have you?
I haven't.
No, you're
Yeah.
you're not going to just all of a sudden have a baby laying in your bed. Like, no, it hurts.
No, right.
It's labor for a reason.
There are a rare, few patients who are able to tolerate pain, like just have crazy pain tolerances, and but as far as sleeping, not so much.
Okay. Wow. Okay. So next question: will I have leaky breasts?
Yeah, probably. Sometimes they even start to leak during pregnancy, and that's, the colostrum. So kind of the high protein discharge that that it produces prior to the milk coming down. So it is important to not really squeeze them, because that can actually stimulate contractions, especially if you're preterm. So wouldn't recommend that. But if they leak, then, a little bit, that's okay. Don't worry about it. And then, of course, after you deliver, then, you're going to have leaky breasts. That's why they make the nipple pads, so that
Get the
you can wear
pads.
those keep your clothes dry.
Yep. Okay. Talk to me about all these weird dreams.
So, yes, dreams can become more vivid.
A lot more vivid.
A lot more vivid.
Crazy.
And we don't know exactly why. There's a lot of stuff about dreams that we, don't know why. But, we think maybe they're, maybe hormonally related, that can increase anxiety and cause more dreams. But also when you're pregnant, you don't, you have to pee at night more often, so you get woken up, and so you spend more time in the REM cycle of your sleep, which is when you dream. And so if you get woken up during that cycle, then you're more likely to remember dreams. So it may not be so much that you dream more, but more so that you remember them.
That's
more.
Probably true. Yeah.
And insomnia is very common in pregnancy from the hormones, and then other factors, getting up to pee at night. So I do see that a lot.
Awesome. Okay. So let's talk a little bit about why you choose to deliver at Bay Area Regional Medical Center.
Yeah, Bay Area is a great place to deliver. I have, patients who request to deliver all the time. And a lot of times it's after they've done the tour. It's a beautiful facility. It's gorgeous. The rooms are really big, really nice, accommodates, visiting grandparents. But more importantly, the people who, the nurses, postpartum nurses, and the NICU team that run the everyday functions are really take good care of the patients.
Awesome. Okay, so let's talk about you real quick. Why did you want to become a doctor?
I actually wanted to, when I was really little, wanted to check people out at the grocery store. So I did not know I wanted to be a doctor at a very early age, but I, had some exposure to seeing physicians interact with patients in high school, doing medical mission trips, and I don't know that there was really one thing that made me want to become a doctor, but just obviously wanting to help people. But there are a lot of professions out there that can help people. I just thought that with my abilities, that was the best fit for me.
So why'd you choose OBGYN?
I did not know a lot about what OB-GYNs did going into medical school. I did my rotation, and it was just exciting. And I just love the idea of being able to have the continuity of care, and being able to see the same patient and then deliver their baby is just really cool and very rewarding.
Awesome.
And you have to make that decision actually pretty quickly in medical school. And I just got lucky that I love my job now, and I made the right decision.
Awesome. Tell me a little bit about your background in education.
I also am an Aggie, went there for undergrad, and then I'm from Dallas, so went to College Station for undergrad, then went up to TCOM, UNT Health Science Center for medical school in Fort Worth, and then went to did my OB-GYN residency training in Chicago, and then I've been here since.
Okay, so before we go, why don't you give us where your office is located, and if someone wants to make an appointment with you, how do they get in contact with you?
Okay, our office is located on 17 Professional Park, and we're about I think there's 2 stop signs in between us and Bay Area Regional. So we're really close to the hospital. And then you can reach us at 281-332-9511. And then our website is www.baobgyn.com.
Awesome. Well, thank you so much for being on the show today. Loved having you guys and talking about babies and embarrassing questions. So much fun.
Thanks for having us.
Yeah.
Thanks,
this was
Abby.
fun. This was fun. And next week, we're going to talk to Dr. Holt, who is an orthopedic surgeon. We're going to talk about shoulders, and we're going to talk to Bob Fuller about keels and wheels. So you guys come back next Tuesday at 4. We'll see you then. Have a good week.